Well, good evening, everybody. Thank you for joining us this evening. We welcome you. We'd love to introduce our program for this evening. On behalf of Edge Endo, my name is Chris Rabbit, Vice President and General Manager here at Edge. And really do appreciate you taking some time out this evening to join us for a real unique program. Technologies for Advanced Cleaning and Disinfection in Endodontics, overview from an experienced academic program. We're very fortunate this evening to have Dr. Fred Barnett joining us. All of you probably know Dr. Barnett, but Dr. Barnett is the chairman of dental medicine and chair and program director of postdoctoral endodontics at the Albert Einstein Medical Center in Philadelphia, Pennsylvania. He earned his DMD degree in 1978, certificate of endodontics in 1981 from the University of Pennsylvania School of Dental Medicine. In 1986, he received his board certification in endodontics and then went into private practice for about 31 years. Just before taking his role as the chair and program director at Albert Einstein, for which he's been there for the last 17 years. So certainly it's great to have him here with us this evening and talking a little bit about how he's been able to incorporate new technologies into his postdoctoral program and his and expose his residents to new technologies in advanced cleaning and disinfection within endodontics. He's got an excellent recipe for doing this, and he is really taken the lead as a program director amongst a very esteemed school and has been able to do this quite successfully. So he's here to share his perspectives a little bit this evening and talk more specifically around really what the program has been able to do in the area of laser-assisted endodontics. So he'll talk about all of these technologies as a supporter, but certainly, talking specific more around his experience and his residents' experience in moving forward with incorporating YSGG lasers in the field of endodontics. So we welcome him. Couple housekeeping rules. There is a tab for answering questions. We're going to try and make this as informal as possible. Dr. Barnett will speak with us for a while, and then certainly please go ahead and type in your questions. I'll go ahead and collate these questions, come back on screen at the end of Dr. Barnett's presentation, and we'll have an interactive dialogue on the questions that you have asked. So again, we welcome you. Thank you again for taking time out this evening, and I'm going to hand it over to Dr. Barnett. Thank you so much.
Great, thanks, Chris, and welcome everybody. Thanks. Uh-oh.
Gotta go back down to
the. Okay, I think we're back up. Chris, we good? Nope.
Yep, you're looking good.
Okay, so I don't want to destroy the presentation on my laptop here, but thanks, Chris, and I appreciate the opportunity to kind of talk about lasers and endodontics. At Einstein, we have, looking at the right, we have that red Ferrari looking thing. That's the BioLase I+. We have the Edge Pro right here below. We have the Photona laser, and we have the Gentle Wave. It's actually like an embarrassment of riches that we have. So I totally feel blessed to be able to have this type of technology and to expose my residents to it. So the BioLase I+ and the Edge Pro, they're both erbium chromium YSGG laser wavelength. So the laser wavelength is exactly the same. The Photona that you see here, this is an erbium YAG. So the wavelengths are actually pretty close together. Their main chromophore is water. And then we have the Gentle Wave, which operates in a completely different fashion. So we've been using the BioLase and the Edge Pro and the Photona really for a few years already. I think the class my first year class, this will be the 4th class of residents that I'll be training on, laser technology. So for everybody who's not from Philadelphia, I warmly greet you. We have the Constitution Center, the Liberty Bell. Most people seem to know Philadelphia because of Rocky. But Philadelphia is kind of like the birthplace of endodontics, and we had Ivy Bender, Sam Seltzer, and Louis Grossman. So these are our endodontic Rockies, if you will. Most people also know Philadelphia for the cheesesteaks, and the two most famous places are Pat's and Geno's. And if you're going to eat stuff like this, you really need to know where the nearest emergency room is in case you develop chest pains. So Einstein is where I've spent the last 17 years of my career as program director and chair of the Ivy Bender division. So this is kind of my home away from home. Financial disclosures, I don't receive royalties for any product from any company. I don't get consulting fees. I'm not on anybody's payroll. I don't have stock options, and I don't get commissions from sales. So I probably will get, or at least I hopefully will get, an honorarium for this lecture. So I'm going to start out showing just several cases, all done by my residents. And the ones you're going to see are kind of probably the cases done in the first maybe 3-4 months of being trained on lasers. And one thing that became absolutely crystal clear to me is that it made the difficult case significantly easier to manage, easier to clean the chamber, easier to kind of see nuances of the color map, easier to negotiate to patency. So everything about the use of lasers in endodontics, specifically for activation of our irrigants, to me is absolutely an amazing no-brainer and just a fantastic adjunct to what we do. So when you look at cases, one of the things that I really kind of what has interested me is the connection between the canals. And the only way you can really demonstrate things like this is obviously by removing more of the tissue and debris and biofilm that's there. Do we remove all of it? I can't imagine that we do, but it's certainly more than kind of what we're used to seeing. So case after case with new residents using new technologies has really been an eye-opener. And so myself and my faculty, we're kind of looking at these cases and we're going, we're not sure we were that good when we were kind of in our training programs. But the issue here is the ease of which everyday cases and the more challenging cases, how much easier it is to navigate and manage these cases. So this distal buccal that you see here, patency was not able to be achieved with hand files, and we have all the tricks. You know, you shape short of the patency area and you do the endo dance with a lot of pre-bent files, and we're never able to get it. So we kind of run the laser protocol, and I'll go into detail in a little bit about the specific protocol that we use. And then when we obturate the case, we kind of see that there is root filling material, obviously sealer, that kind of gets to the area of patency. So some people call this laser patency. The interconnections between MB1 and MB2, a deep palatal split, you know, these are great. People love kind of seeing, you know, really fancy obturations. But what's more meaningful to me is when we're activating our irrigant, the amount of debris that we see coming out of the canal orifices. So the enhanced cleaning and disinfection obviously should lead to a superior looking obturation. C-shaped canals, yep, always challenging. And with the use of the ERCR YSGG lasers, right, it's really not a huge challenge at all. And you can see the amazing interconnections between like the two main canals of the C and all the intricate webbing that's in between these two main canals. And here's another one. It kind of looks like a squid almost, C-shape, and tremendous amount of tissue coming out, which gave us the ability to kind of put more sealer and some warm gutta percha into the canal system. So we don't usually take post-op cone beams on cases, but what this shows on the mesial root that you see here, again, is the tremendous interconnections, the isthmuses that exist between the MD and the ML. So we're filling anatomy that you absolutely cannot visualize on a two-dimensional image. So it really tells quite an interesting story. And this is another one where we see this intricate webbing, this anastomosis between the two mesials and the two distals. And if you kind of look here in this PA on the bottom in the middle, there's a mid-mesial, or maybe it's just an interconnection of the webbing that we were not able to kind of find or negotiate from the chamber floor, but where it's being filled kind of in a reverse manner, so to speak. So clearly, the more tissue and biofilm and debris that's removed, there's a greater opportunity to fill these spaces with our root canal sealers. So this premolar was a retreat by one of my residents. Post comes out. Thankfully, the crown came off. And using the pre-op combing, we kind of knew there was, complex anatomy. But after we do this coronal conditioning step, which we could also call like chamber debridement, where we're running laser activated water or irrigant in the chamber for maybe 60 seconds, maybe another 60 seconds, you're able to see through your microscope the intricacies of multiple portals of entry that we see here on this post-op. So everything has been made a little bit easier in terms of management of, certainly this is a difficult case. So lasers stand for light amplification by stimulated emission of radiation. And you're all lucky tonight, we're not going to do laser physics, except for one or two slides. The erbium lasers, so the YSGG and the erbium YAG, you see here, it's mostly absorbed by tissue that has water content, obviously our irrigants, and hydroxyapatite, which is your dentin. So this is a perfect wavelength for activation of our irrigants, because the irrigants absorb the laser energy, which causes now a reaction in the irrigants themselves in terms of cavitation bubbles, shock waves, shear forces, all which are used to kind of break up and debride and dissolve tissue that ordinarily would remain in the canal. So the question has to be, we've been doing endo, right, for a long time. Most people seem to be satisfied with the success rates, and therein lies a problem. We should not be satisfied with our success rates, especially on teeth with apical periodontitis. So one question could be, do we have a problem in endo that's looking for a solution, or do we have a solution now, right? Is there a solution looking for a problem? To me, it's clearly that we have a problem, right? We have a problem where we should be able to get the same exact outcome of teeth with apical periodontitis as we get with our vital cases. The only difference between these two types of cases is the presence of necrotic tissue and biofilm. And this cross section here, this H&E slide, you clearly see where the niti rotary kind of made the round shape, and there's an isthmus filled with tissue, and even this canal on the left side has remaining debris. So instrumentation, we know, doesn't touch everything, and nor should it. I think it would be impossible when you look at the micro CT anatomy. So clearly, irrigation and advanced irrigation is absolutely critical to help dissolve, disrupt, debride, and chemically dissolve all the tissue that's left behind. So one of the factors, and this has been shown almost forever, in terms of the outcome or predicting the outcome of endodontic treatment, teeth with apical periodontitis has a lower success rate than teeth without AP. So when a patient presents with an apical lesion, there's already that tooth is like maybe a 10, 12, 15% lower likelihood of having complete healing. And apical periodontitis clearly is a biofilm disease. So the preponderance of all the evidence in all the lit that's available is that improved disinfection has led and will lead to improved outcomes. Infected canal systems really can't be predictably disinfected with traditional cleaning and shaping in a single visit or in multiple visits. So, but it's, yep, we still get 85% success. So, but we should really strive for higher. Advanced materials, advanced methods, again, gentle wave, lasers, photoactivated disinfection, nanoparticles, microbots, all of these things we're hoping will allow for enhanced and predictable disinfection, ultimately with improved outcomes. And pretty much the caveat on every study is that additional high-level studies are required to achieve reliable best evidence. So is sodium hypochlorite the problem? Why we're not being able to disrupt biofilm, dissolve necrotic tissue, and kind of flush out all the debris? Nope, it's not the sodium hypochlorite. It's always been shown that the way we deliver our irrigants into the root canal system is the issue. Does it reach the apical third? How do you get all the debris out? And then the question I always like to ask is, what do you think is actually happening when you're irrigating the canal with even the 30 gauge closed end side port needle? What every study has shown is that the irrigant is not really getting much past the tip of the irrigating needle. So if the irrigating needle is, handful of millimeters short of working length, it's not going there, right? And certainly that's an area that can be improved upon. So when you look at this image, it's kind of like, wow, isn't it amazing sometimes that we have the high success we have on teeth with apical periodontitis because we're not getting the irrigant where we need to. And maybe that's the missing link here, is to kind of get the same exact outcome on teeth with AP as we have on the vital cases. So some of the advantages that have been published on laser activated irrigation is improved reduction of endodontic pathogenic bacteria, E. faecalis, and yeast, debris and smear layer removed in 60 seconds, 120 seconds, 3 times greater reduction in colony forming units compared to the highest concentration of hypochlorite. And irrigant can reach and has reached the apex without extrusion, which is, for me, kind of this is what is an absolute must. There should be a zero tolerance for sodium hypochlorite accidents. So laser activated irrigation, the mechanism of action, it's really all about the bubbles. So this is kind of a shadow graphic image, but essentially what happens is the erbium wavelength, YSG wavelength, is absorbed by the water molecules superheat, and a vapor bubble is created. So the vapor bubble really begins to expand. It can't keep expanding forever. It collapses. When it collapses, a shock wave is emitted, and this initiates secondary cavitation bubbles, and the cavitation bubbles will cause shear forces and acoustic streaming throughout the entire canal system. So water molecules or irrigant molecules absorb the laser energy, they expand up to a point. When they collapse, now a shock wave is created, cavitation bubbles are formed, shear forces are generated, which is actually what disrupts the necrotic tissue and biofilm off the canal walls. So I want you to take a look, and I'll play each of these videos. So this paper is talking about the working mechanism of laser activated irrigation and its action on microbial biofilms. So these are not root canals. These are root canal looking glass structures filled with this kind of gel, which is supposed to be like a biofilm. The laser tip is just above the orifice here, and this video on the left, you're going to see a single pulse of an erbium laser. And then what I want you to notice is, as this begins to happen, look what happens down towards the apex of this canal. Bubbles expanding, it collapses. It's already having an effect down towards the apex of this simulated root canal system. The video I'm going to play now is, it's sped up, but it would be a cycle of 20 seconds. So when we activate our irrigants inside the root canal system, we do 30-second cycles. So take a look at this. So this is the laser tip kind of at the orifice. Again, this is sped up, and this is going to show what would happen at 20 seconds. So look what's happening down towards the apex, right? So first, please notice that it takes time to kind of remove whatever was placed in these tubes. Same thing in the canal system. So we need multiple cycles of 30 seconds each with our irrigants. So this is kind of the working mechanism. And what you got to see is that here the laser tip is basically above the orifice. I think, and I'm going to show some evidence as to why I believe it's beneficial to bring the laser tip down into the canal to about mid-root as you do this type of activation. So this is from that study. You can kind of see at 0 seconds, it's already having an effect. 5 seconds, it's beginning. At 20 seconds, it's mostly gone. So it's a hydrodynamic effect. There's a generation of these cavitation bubbles that extend throughout the canal system, causing these shear forces and shock waves to break up all of the tissue and biofilm that's in the canal system. So again, laser-induced cavitation, it's all about the bubbles, and it takes time. It takes time for it to reach the intricacies in the apical portion of the canal. So at what should be on everybody's mind is there going to be, one, extrusion of irrigant out into the periapical tissues, and are we really getting the irrigant to penetrate towards the full length of the canal system? So this was an in vivo, right? So real patients, live patients, 40 patients, single-rooted teeth, wide open apices, and they all had apical periodontitis. The sodium hypochlorite was mixed with a radiopaque contrast medium, so you would be able to see the presence of the contrast medium in the canal when you take an image. So the YSGG laser was used. This is the #1 tip. It's 200 microns, and this was again kept at the level of the orifice for 60 seconds. So why not take it down the canal? Well, these are teeth with wide open apices, and it compared to passive ultrasonic irrigation with an IRISAFE tip, 50% power, and that was brought 2 millimeters short of working length, also for 60 seconds. So what we see here is the number and percentages of cases where the contrast medium reached the apex, like you see on this radiograph. All 20 of the 20 on the laser, the contrast medium reached the apex. So yeah, it clearly went the whole way. On passive ultrasonic activation, it did not. It only went about maybe 50% of the time. More importantly, on the imaging, there was no extrusion beyond the apex on either group. The laser group, as I mentioned, the contrast medium reached the apical extent of the canal system in all 20 cases, whereas the passive ultrasonic irrigation group, it only in about 9 of 20. So clearly in this type of study on patients, clearly it appears to be safe, no extrusion of irrigant, and you're getting the irrigant to the full working length. So this is an ex vivo study on 30 single-rooted human teeth, Just look at the highlighted stuff in yellow. I know this is kind of death by PowerPoint. The extracted teeth were enlarged, inoculated with E. faecalis and Candida, allowed to incubate, and then 3 groups. They had the erbium YAG, they had ND YAG, and the YSGG. The erbium YAG, the tip was kept in the access, which is kind of the protocol for pips and sweeps. You keep it in the access cavity. The ND YAG, it was moved up and down the whole length of the canal. The YSGG, again, this is the tip number 1, 200 micron tip, was down the canal about mid-root, 5 millimeters from the apex. And this study, only saline was used, so no hypochlorite, no EDTA. So after they ran the erbium, the ND YAG, and the YSGG, they kind of looked to see, you know, how good was the disinfection. And kind of what they showed was that both erbium lasers did a really good job of significantly reducing the microbial content of E. faecalis and the yeast. ND YAG basically did pretty much nothing, but the YSGG eliminated significantly more of the microorganisms compared to the erbium YAG. So the YSGG clearly was, and statistically significant, most effective of these 3 wavelengths, performed better than the erbium YAG, and it's kind of understood that it's because the laser tip was positioned more apically. Again, no hypochlorite or EDTA was used. So the antimicrobial effect was basically due to the activation of sterile saline, right? So attributed to the photodynamic, the mechanical effects of this rapid fluid movement, the shock waves, cavitation, and shear forces. So I'm using this result to basically kind of explain why I prefer kind of taking the laser tip down into the canal to about mid-root. I think this is very clear, this evidence. So how do we do this? How do we do this clinically? So the beauty of these lasers is that you don't have to change any of your technique. You use whatever hand and rotary files you use. You could enlarge and shape the canals as you normally do. The workflow is just as easy as anything. So I usually will tell my residents, occasionally they do listen, after each instrument, instead of picking up a hand syringe, I'm picking up the laser handpiece, right? So there's nothing to build up. It's extremely beneficial as part of our workflow. So let's talk about the clinical technique and the steps. So you're going to make access. We're going to use blockout to keep irrigants from leaking out and saliva leaking in. On a vital case with a lot of tissue, we just want to try to excavate as much as they can. And we're going to be starting with tip number 3 on the Edge Pro. That's the 500 micron tip. We're going to keep the tip about 4 millimeters above the floor of the chamber. The settings we're going to use are this 1.5 watts, 20 hertz, which gives us 75 millijoules. And we're going to do it with air and water. And we're going to do 30 seconds, take a look, another 30 seconds, take a look. If there's still a lot of debris, then we're going to do another 30, 60 seconds until the chamber looks clean. Alternatively, a lot of endodontists prefer to do this coronal conditioning or this access debridement step, not with water, but with continuous flow of irrigation. And you can see this picture here on the bottom. There's an irrigating syringe here. This is the laser tip, and the irrigating needle is kind of just squirting hypochlorite into the chamber, and the suction is right next to it. So if you're going to do continuous flow of sodium hypochlorite, we need to lower the energy on the laser. So instead of using 75 millijoules, we're going to do 25 millijoules, which means instead of 1.5 watts, 1.25, instead of 20 hertz, we're going to change it to 50 hertz. So very easy to kind of increase or decrease the settings on these lasers. So for my GPRs, and in the beginning, we're basically doing it with air and water on. If you have an assistant, and even if you don't, and you decide to do it with hypochlorite, you just change the settings and you're good to go. So this is what this coronal conditioning kind of looks like on a picture. Your laser tip is here, and this is a picture courtesy of Giovanni Olivi. You're squirting in irrigating solution here. And again, what we see here is this bubble. This is this molecule of water or irrigant. It's now absorbing the laser energy, it's expanding, and eventually will collapse. But before it actually does collapse, look at what's happening down inside the canals, exactly like that video that I showed you before. So it's not just cleaning the chamber that this coronal conditioning step accomplishes, it's actually beginning to send irrigant down the canals to disrupt, break up necrotic tissue and biofilm. So this is an extremely important step. So this is our step one. And this is a video in our clinic. This is, you kind of see there's a suction tip here. This bent needle is, we're squirting in hypochlorite while the laser handpiece is just kind of moving around the chamber. And again, we want to keep the tip of this laser about 4 millimeters off the floor of the chamber floor. And again, what you see, this little video that's happening, this is kind of what we expect to see and what has been shown to be the case. So access is made on this irreversibly inflamed tooth. It's kind of bloody. You don't really know now where to kind of go. We're running our laser, this one, right, hypochlorite, 30 seconds, another 30 seconds. And then you clearly see if you want to open up or widen the outline of the access cavity. So it kind of goes from the picture on the left to the picture on the right. And this is before any files are brought down into any of the canals. So this is a fantastic and really effective first step. So this image on the left is kind of, after some of the coronal conditioning, all the caries, defective restorations are removed. You see a lot of calcification here on the floor. So we're going to run this coronal conditioning step, another 30 seconds, 60 seconds. A lot of the calcification is removed, but you clearly see kind of where the entrances to the canals are. So it's really taking some of the guesswork out of it. And then you just need to kind of, with an ultrasonic, pick this stuff out and then continue on. There's a retreatment case, and you can't even imagine what must be growing in here. So you're using your laser, again, 75 millijoules to kind of really blast out all this debris. And this is what it looks like maybe after 60 seconds, maybe after 2 minutes, before any files are brought down into the canal. So it's doing a debridement, and it's also disinfecting the chamber itself. So as we bring instruments down into the canals, hopefully we're not transporting a lot of this mess down the canals. So access is complete. We've done that first step, the chamber debridement, the coronal conditioning, and now you instrument the canals how you always did it. So whatever your system, whatever your technique, you keep going. What I recommend is that after every file or every other file, we're going to do the same coronal conditioning step, the same tip number 3, same settings, about 10 to 15 seconds over each orifice. So this will absolutely kind of blast out any debris that's kind of created by the action of your hand or rotary files. So we do that, then we suction the chamber to take the water out. We'll fill the canals with a syringe, fill the canals and chamber with hypochlorite, and go to the next instrument. And then after every other instrument, again, we're going to kind of use the coronal conditioning step to kind of really blast out all the debris. And when you watch this happen through the microscope, it's really amazing how clean everything looks with this step. So now you've completed your instrumentation. We're changing to tip number 1. This is the 200 micron tip, which is kind of the same size as the tip of a size 20 hand file. And now we're going to bring this tip to about mid-root or in the coronal third. And then we're going to activate as we remove the handpiece, and we're going to keep the tip just within the orifice for 30 seconds. The settings we use are 1.25 watts, 50 hertz, 25 millijoules. Air and water is turned off. So this is the sequence of how we do it. This is our protocol. So you've completed the instrumentation. Tip number 1, we're going to bring the tip, again, mid-root to the coronal third, and then we're going to be irrigating with hypochlorite for about 30 seconds. So each canal is going to have laser activation with hypochlorite for 30 seconds. So how much? What's the volume? So each 30-second activation, we're using about 6 ml of hypochlorite. So we recently purchased 12 ml syringes. Each 30-second cycle, we kind of squirt in 6 mLs. So it might be a lot more, and I know it is, a lot more irrigation than I think any of us had ever done. So it's 30 seconds per canal, right? The laser tip starts mid-root. As we're activating and squirting, we're kind of withdrawing the tip, keeping it just within the orifice for 30 seconds. So we do 1 round of hypochlorite, then we do 1 round of EDTA, and then we do a final round, again, of sodium hypochlorite. So it's a lot of hypochlorite, which is really the key. So the more laser activation, the better the hydrodynamic effect, the better the cleaning and disinfection will take place. So you really need time, right? Time for laser activation and volume of bleach, kind of what we all knew from before. Once we're done with those 3 cycles, 1 hypo, 1 EDTA, and 1 final hypo, we're just going to use the same tip, same settings. We're going to turn the air and water on. This is just a final rinse, 30 seconds per canal. And then you're ready to dry the case and then obturate. So look at this. So this is really something. So this was probably within the first week of us getting the YSGG laser, right? So this was a canal that was fully instrumented, right? We activated the irrigant with Erie Safe, so we did ultrasonic, passive ultrasonic activation. We had the laser, and it was like, okay, what would happen? What would we see if we kind of fill the canals with an irrigant, take the YSGG tip, the 200 micron tip, bring it to mid-root, activate it, and we slowly withdraw it and keep it at the level of the orifice for 30 seconds. Well, it should be, well, no debris should come out because we've done all our irrigation with ultrasonic, so what could be left? And this is, take a look. This again, after passive ultrasonic, look at the cloud of debris that's coming out. Again, this probably was one of the first things we did with the laser. So clearly the passive ultrasonic irrigation is not really doing kind of what we expect it to do, but guess what? The literature also kind of confirms that PUI isn't really giving us fantastic results. Is it better than just hand syringe? Yeah, it absolutely is. So this is a protocol that I'm saying I got from a lecture with Giovanni Olivi on lasers. After all the instrumentation, 30 seconds per canal, the laser tips are brought to mid-root. As you activate, we kind of slowly withdraw the laser handpiece, and then we keep it at the level of the orifice for 30 seconds. So 1 round of hypochlorite, 1 round of EDTA, the final round of hypochlorite, and then finally with water. So this final step is tip number 1. It's the 200 micron tip, and it's 25 millijoules, so it's 1.25 watts, 50 hertz. And this is kind of the protocol that we honestly try to follow on every single case. So we have a certain amount of volume of irrigants. There's a certain amount of time that we activate these irrigants. And all of that together, hopefully, is going to give us the results that we really want to see. So I'm going to show you a handful of cases from some endodontic colleagues. This is Francisco Banks. He's been using the lasers, the YSGG, for several years. When we started, I know him quite well. I kind of was talking with him all the time for tips and tricks on how to do this, how do I teach my residents, and it's kind of pretty much exactly what I outlined before. And there's a case from Charles Maupin, also using the YSGG laser. So, and it's really kind of, yeah, it's remarkable. It's absolutely remarkable what we see. Here's another really intricate C shape. I kind of told him it's almost as good as the ones my residents did, but yeah, it's really nice. This resorption case, again, this is being filled. This is with BC Sealer. Actually, no, I'm sorry. Charles uses Kerr EWT sealer. So it's a ZOE-based sealer, so you can get the same exact results with AH+, Kerr EWT, or any of the bioceramics. So laser patency, you hear a lot about this. So when you can't achieve patency, right, with all the tricks that you know, we're typically going to shape just short of the ledge or the blockage or whatever it is. We're going to use tip number 1, 200 micron tip, just short of this obstruction. Never allow the laser tip to bind, because if you do, you may have some ledging that you created because of the laser ablation of dentin. So knock wood, we have not ledged a case in our grad program where we had any difficulty getting gutta percha to length. So the laser tip goes there, air and water on, you activate and slowly withdraw the laser tip, again, 30 seconds at a time. And then if you can't get mechanical patency, meaning with small pre-bend files to go to patency, then you're going to finish the case. So here are a couple where this is exactly what happened. Again, resident cases from Einstein, you kind of see this intricate complex at the apex of this mesiobuccal root of this maxillary molar. Clearly, there's no way that we were able to get, because I know this quite well, instruments to kind of get to patency on all these. So this was BC Sealer and mostly single cone. So how does this happen? Well, it's the activation of our irrigants with the laser energy that again causes bubbles to expand, collapse, shock waves, cavitation bubbles, shear forces, disrupts biofilm, breaks down tissue, and allows it to be kind of rinsed out. There's another case where you have this like deep apical split or this large lateral canal. Again, it's the same, the steps are pretty much all the same. Where we're doing coronal conditioning with the tip number 3, this was done with water. You do your instrumentation, you're activating irrigant after every instrument. When you're done instrumenting, we switch to tip number 1 and we do continuous flow of 30 seconds per canal hypo, 30 seconds EDTA, and a final 30 seconds with hypochlorite. Rinse it and then obturate the case. is another one from a resident that recently graduated. You have this like crazy little split in the apical part. And what this is showing, yeah, patency was not mechanically achieved. You see the interconnections between the two mesials and the two distals. And these 4 canals, so it was 4 single cones, all with BC sealer. So the fact that sealer is going to kind of get into areas, it means that more tissue, more debris was removed in order for that to happen. This deep split case is from Dr. Julie. I'm assuming she's on tonight. So a bunch of cases these are the last month in our program. Deep apical split, unable to achieve patency on either of these. Again, this is with the Edge Pro, same protocol, tip number 3, the 500 micron tip, water only. You instrument the best you can. And then final irrigation sequence, tip number 1. It's a lower amount of energy, EDTA, hypochlorite, and 24 mLs of hypochlorite. I mean, it's pretty much more than I think I ever used per case in my entire career. But this is probably kind of the right amount. And you see the results that are achievable with this. Another recent case, these were all done before we all went to apices. And I think, yeah, she instrumented that lateral canal on this retreat case with a number 10, but good luck trying to enlarge that. So you're taking advantage of the physical action of laser wavelength on the liquids. Again, it's cavitation, shock waves, and shear forces. So this is the magic of it. This is the magic. You know, deep apical splits, areas where you can't get patency, you're clearly filling with sealer. So does this mean these cases heal 100% of the time? No, of course not. But the amount of debris that you will see that comes out of these canals when you're looking, you know, through the scope, it's more than you'll have ever noticed with any other type of irrigation delivery. Again, canals where difficulty getting patent, canals that exit at 90 degrees. Again, the protocol is the same every time, right? Coronal conditioning, we're using the same thing after every instrument. Once we're done instrumenting, we're bringing the tip mid-root, activate on the way out with 3 cycles of hypo, EDTA, and then hypo again. So take a look at this case. This friend of mine, Gary Glassman from Toronto, very well-known guy. This is a case week number 1 with the YSGG laser in his practice. He gets this monstrosity. You see the wire film here, and like that was it. You know, he's extremely talented and extremely experienced endodontist. So he's doing the protocol with the YSGG laser exactly the way I outlined it to you. And this is BC Sealer, obviously. He was kind of amazed. He told me when he kind of was taking this image, you know, you give a little prayer, you know, before the sensor picks it up. And it was kind of mind-blowing to him. And when you look at this case, it's like, wow, that's pretty remarkable. That's pretty remarkable. While the workflow, where you're picking up a laser handpiece, you know, in the beginning, after each instrument, and then at the end, there's nothing easier than doing this. So we're kind of coming to the end. What I think is really important, and it's what I've been hearing for the last 3.5 years, is an argument against considering laser activated irrigation or use of lasers in endo, is that there aren't any really good outcome studies saying it's better. Well, I guess if you want to wait for a 5-year outcome study that is going to be perfect, you may be waiting a lot more than 5 years. So believe me, do I want improved outcomes? Absolutely, every time. But it's not only about outcomes. With the use of the laser, the way I outlined it and the way others have, is it makes it easier finding canals. Again, that's the coronal conditioning step. Negotiating to patency. We see this almost every day. You clearly visualize enhanced debridement because you're seeing an unbelievable amount of debris coming out of the canal orifices, more than I think you've ever seen in the past, and it simplifies the workflow. So it simplifies the endodontic procedure, and I can tell you this is without a doubt a remarkable thing, because I'm watching residents do this, and I've been training residents at Einstein for 17 years. And when I see cases like this on new users of lasers, I mean, it's really remarkable. So my residents have said to me, you cannot unsee how clean the chamber is, how clean the canals are, at least the part that you could see through the microscope, and how clean the isthmus areas are between canal orifices. You can't unsee this. You can't unsee this. So the mind, once enlightened, cannot again become dark. So that's it. May the force be with you. We certainly have time for some questions, so we'll give it back to Chris.
Thank you very much, Barnett, for that wonderful presentation and for sharing with us how you've been able to incorporate these technologies so successfully. Yes, we do have some questions, and I remind our audience, if you do have a question, there should be a little question tab on the right side of your screen, and you can go ahead and type those in. I do have a couple that we'd like to ask you here, Dr. Barnett. Are both first and second year residents getting exposed to these technologies?
Oh yeah, absolutely, absolutely. So after tonight's presentation, my first year residents who started July 1, tomorrow we're going laser all the time for them.
So on mostly every case, you are incorporating some form of advanced disinfection and cleaning.
Absolutely, every case, every time.
Yeah, and with access like this, unprecedented access available, has one emerged as a favorite amongst your students?
I think the one that they're using always is their favorite. So I don't really have an answer for it. I have a preference, at least in terms of lasers, that I want to be able to bring the laser tip down the canal to mid-root as my final irrigation process. And teeth that are broken down, yeah, you just build up a little wall with like opal dam, and you're ready to go with the laser. So they're all great. I'm happy that we have such an amazing variety. But I mean, yeah, I don't know what to say.
Yeah. Well, I guess on that topic, there are a couple other questions. Can you expand on GenaWave versus laser?
Yeah, so the GenaWave, we have cases that look like this with the GenaWave. If you have intact coronal tooth structure and you cut an access and you build your platform, then the instrument GenaWave is going to do a really beautiful job for you. When teeth that are broken down, you really better have a good buildup and a good seal. Otherwise, hypochlorite may leak out. The mechanism of action is not going to be the same. So depending on the condition of the tooth that you're about to treat, you may have a preference of one device over the other.
They're drilling down on this topic, Dr. Barnett. So are you saying that YSTG and Edge Pro is easier to incorporate into your workflow than other technologies like GenaWave in a broader application of cases?
Yes, yeah, that's exactly what I'm saying.
Okay.
And
Is it
I'm
a good idea? Go ahead.
and
I'm
I'm
sorry.
and I'm speaking from the case types that we see in my program, right? So we're not getting all beautifully restored teeth that need endo. There are a lot of broken down teeth where you have to clean caries, there are defective restorations, and this takes time to do an adequate buildup, right? So the workflow, my experience with my residents, the workflow is more challenging. When we're using the laser, we could easily kind of build something up, with an opal dam or blue blockout or whatever, and you're ready to go. So sometimes the pre-endo buildup is way more difficult than the endo, right? And it takes a significant amount of time. So yeah, I mean, it is what it is with that.
Fair enough. There's some specific technical questions. What percentage of sodium hypochlorite is suggested or do you use within your program?
Yes, we're using, when we're activating with lasers, 2.5%. I have a bunch of colleagues that all use full strength. I think Charles Maupin uses full strength. Francisco Banks uses full strength. I decided we're going to go with 2.5% because we're learning, right? We're all learning as newbies on the laser. So I'm just want a little bit more of a margin of safety.
Excellent. Is it a good idea to block one canal and then irrigate and use laser energy on the other canal so that the debris doesn't go from one canal to the other?
It will never, the debris is never going to kind of jump into another canal because there's such cavitation where it's all kind of coming out of the chamber. So that I don't believe will ever happen.
Yeah. Final rinse with water with the laser. Are you concerned about not having a hypochlorite accident?
No. I mean, we're activating hypochlorite with the laser tip halfway down, right? So let me answer it this way. Yeah, I'm absolutely concerned always about having a hypochlorite accident, right? In 31 years of practice, never had one. All the years of teaching, we never had one, but it should be on everybody's mind. And I mentioned in the beginning, you should have a zero tolerance for any hypochlorite accident. What we have, and I kind of showed an in vivo study on the teeth with the open apex and apical periodontitis, that there was no evidence of extrusion on the hypochlorite that was mixed with contrast medium. So, and again, we're not bringing the laser tip all the way to working length. We're never doing that. We're bringing the laser tip to mid-root only after the canals are shaped. So the laser tip is not binding, and as the cavitation effects are happening, it kind of comes up and out of the canal, because not only are we activating, but we're slowly withdrawing the laser tip. So I hope I'm explaining this right.
Very clearly.
Okay.
Have you tried not instrumenting MB canals and seeing if your protocol will allow sealers down to the apex?
Not on patients, I won't. If canals are starting out, young patient, canals are really wide, yeah, obviously you don't need to instrument them, right? There's no reason to take off dentin if the canal has a natural size of, 30 or 35, whatever. Yeah, so then we want to kind of get as much tissue out as we can, not cut any dentin, and now do this laser protocol. But what I can say, and what I showed on some cases, there are times where we're not able to reach an isthmus or a fin or an additional canal. And then when we are filling the case and our final x-ray, the final image, we kind of see, yeah, sealer went there. But I would never kind of do this intentionally. My intention is to find all the canals, instrument all the canals, and kind of do the protocol in a very systematic way with the right amount of time and the right volume. right? So a non-instrumentation method on canals that are small, no, won't do that.
Excellent. What about the research with 0.5% sodium hypochlorite Dakin solution?
Yeah, so actually, Dakin solution is what I used when I was a resident because I had a Scandinavian chairman. So if the canals are enlarged and you can get 0.5% down there and you have a lot of turnover of the liquid, yeah, it's as good an antimicrobial irrigant as 5%. But in terms of dissolving biofilm and dissolving tissue, 0.5% is very poor. So if someone is concerned about 2.5% being too strong or too irritating, then use 0.5%. I'm just telling you what I use and what we use, right?
Excellent.
The studies that kind of looked at the antimicrobial effect of E. faecalis and the candida, they were using, I think, 5%. So again, the beauty of this is you decide, you the clinician, what sizes you want to go to, however you decide to do it, you're incorporating this technology into your existing workflow. And in terms of strength of sodium hypochlorite, if you're using gentle wave, it's using 3%. It will dilute the hypochlorite to 3%. So take that for what that's worth too.
Well, if it's all right, we have a couple more questions, technical in nature. I won't keep everybody too late here, but can residents use a laser without an assistant to suction?
Absolutely. So some of the little video clips that I showed, there's a suction tip, right? It's kind of attached right next to the tooth, and you could squirt in one hand, hold the laser with the other. Yeah, is it cumbersome? Sure, but we do it. Anybody who wants to come to Einstein and spend like a couple of hours with us, you're more than welcome. You could see the residents in action and how we use all of these technologies.
Excellent. I'm going to combine a couple of these questions. The doctor has said that they're used to using bleach as their final rinse. So you're saying that water is the final rinse with this protocol, correct?
So I'm not saying anything. if you don't want to do the final rinse with water, that's fine. That's not going to make or break anything. There are some people that want to rinse out the chemicals, and they do. The gentle wave device, the final rinse is with distilled water. So before using lasers, my final rinse was hypochlorite. So I never rinsed it out with sterile saline. So you don't have to. What the important part is the 30 seconds per canal of hypochlorite, EDTA, and then hypochlorite. 30 seconds a canal, and try to do as much volume as you can.
Excellent. Double pressing on this question here. Can you talk a little bit more, and you discussed this, the differences between Edge Pro and the Photona Lightwalker?
Yeah, so the Photona, right, excellent laser. It's erbium YAG, right? So the wavelength is almost identical. It's basically designed where you do not bring the laser tips into the canals, right? So if you kind of look at, and we were trained on it, and we use it. We use it all the time, right? The laser tip stays in the chamber, right? And according to Dr. Olivi, you don't even have to aim it over the orifices. You just kind of keep it in the middle of the chamber, right? I showed some evidence, and I think it's kind of compelling, that you will have a better shockwave, cavitation, acoustic streaming by having the laser tip down the canals as you activate the irrigant.
Great. And as you can imagine, with such great discussion, there are more questions coming in. So, yeah, you know, I will put this one out. It's not so much a question, but I think a relevant comment. For what it's worth, as a user of both technologies, I think the word is disingenuous to claim it's necessary to do a full pre-endo buildup prior to running GenoWave. Every one of us should remove caries first. Then, once the tooth is dry, with alcohol, the sound seal can be used as the pre-endo buildup without issue, if done right. Very, very manageable learning curve. Several laser cases shown today had sound seal barriers in place. It's no harder than that. As a GenoWave user for 3 years and a laser Edge Pro user for 1 now, I now lean 2 to 1 Edge Pro laser to GenoWave, but certainly some teeth set up better for GenoWave, others for the laser. So I think that's a fair comment.
And I think I said the exact same thing.
Yeah. So I just want to make sure everybody is we're representing all the questions and comments here.
Yeah.
So go ahead.
My experience as we're using all these devices, if the buildup or the platform is not done correctly, right? Some people do it much faster than others. Again, we're talking about residents who are new to these technologies. They're not seasoned endodontists that have a device for a bunch of years and have gone through this huge learning curve. I'm telling you, and you could ask my residents directly, if the buildup is not adequate, you will not be happy with the GenoWave. So there's nothing disingenuous about one thing I said, because this is what I have seen with my eyes. So whoever made that comment said they're using the Edge Pro 2 to 1 or 3 to 1. Well, why?
2 to 1. Yeah.
2 to 1. Okay.
Yeah. How would you hold the syringe, laser, suction, and mirror when working on a maxillary tooth?
Whoever, please come visit us at Einstein. We'll show you. How can I possibly describe this in words? But we're happy to. And so let's say you can't actually irrigate. It's too cumbersome, things are happening. So this is what you do. You finish the instrumentation, you're now on the final irrigation sequence. Fill the canals and the chamber with hypochlorite. Put the syringe down. Hold your mirror. Hold, your other hand has the laser handpiece. Put it in the canal to mid-root. Activate. Withdraw slowly. Stay in the orifice for 30 seconds each canal. So I certainly prefer having continuous irrigation during the final protocol, but so let's say we can't do that. This is how you can do it. Fill the canal and chamber with hypo, activate, suction, do it again.
Great. Well, this has been excellent dialogue. I thank you for fielding all these questions. We have a couple more, but I think for the interest of time, I'll put these in email to you, Dr. Barnett. Please note on the screen too, you see Dr. Barnett's email at the bottom. As gracious as he is, I know he would entertain any questions that you'd have for him. Want to thank all the participants for joining this evening. Participants that have been loyal to EdgeEndo, we thank you. Participants that are exploring the use of Edge Pro and laser assisted endodontics, we thank you for your interest as well. And certainly we will follow up with everybody accordingly who have more interest and seek some more information on how this technology is advancing the specialty. I guess I'd leave you with one question. They're just not going to let you go with this one, Dr. Barnett. So here it is. If you could only buy one technology for laser assisted irrigation, which would you choose? GenoWave, Edge Pro, or Sweeps?
Edge Pro. Why? The price. The price, and I want to bring the laser tip down the canals.
Yeah. Fairly covered. So, well, thank you again, Dr. Barnett. It was a great presentation, great interaction, and thank all the participants for joining this evening. We're signing off now. Good night.
All right, good night, everyone.